Just to tell you a little bit about myself first. So my name's Dr. Tracy Dudding-Byth. I am a clinical geneticist. So I've been working as a clinical geneticist for nearly 30 years. I'm also the mother of a child with NF1s. My daughter's now 23 and I'm a clinician researcher. So today I'm going to be talking mainly about cutaneous neurofibromas and our research project, which has just launched, called the Cutaneous Neurofibroma Consortium. So excuse me, just. Okay, so we'll just do a little bit of background first. Most of you probably know this information, but NF1 is the most common neurogenetic condition, and it affects 1 in 3,000 people. The condition is characterised by cafe au lait spots, which are these coffee-coloured, coffee-coloured sort of birthmarks, and it's normal to have a few. People with NF1 usually have more than 6, so having 6 is one of the diagnostic criteria for the cafe au lait spots. Neurofibromas, which are the lumps that can appear on the skin. Skin freckling, which tends to occur in the axilla or in the inguinal region, and these leash nodules. And these are benign growths that occur in the eye. They don't cause any problems, but they're quite diagnostic when they're seen of NF1. So the condition is inherited in an autosomal dominant manner, which means that adults with NF1 have a 50% chance of passing the gene change causing NF1 on to a child of either sex. However, 50% of the time there isn't a family history, and the person with NF1 is the first person in the family to be affected. And what's happened there is that the change in the NF1 gene has occurred out of the blue by chance, either in the egg or in the sperm, or shortly before or shortly after they've come together. And there's nothing that would have caused this to happen or prevented it to happen. It is a chance occurrence. So NF1 has a number of features, but my research is relating to the cutaneous neurofibromas. Before we go on to that, I just wanted to revise some of the other features. So about 30 to 60%, these are some of the more common other features that individuals may have, but learning problems is really experienced, and individuals can have problems with executive function, memory and language, and often they have a particular type of dyslexia called phonetic dyslexia, where they have a little bit of difficulty sounding out words, and often they have to learn words by sight. Despite this, learning is difficult, but they can achieve, but they do need a lot of individuals need extra learning support. So for example, my daughter had a specific learning disability and struggled at school, but worked incredibly hard and managed to get into university and complete her Bachelor of Psychology studies. And she's now working with adults with early intervention for adults with autism. So it is difficult and it's challenging, but people can achieve with this condition. Optic gliomas are seen. This is a benign tumour of the optic pathway, which can interfere with visual acuity, which is why we screen children when they're younger. Plexiform neurofibromas, I'll talk a little bit about them a bit later. They are different to the cutaneous neurofibromas, but they tend to occur in adolescence or they tend to occur in childhood, but they can be complicated by a malignant peripheral nerve sheath tumour, which tends to occur in adolescence and early childhood. The other complication, hypertension, can occur at any age, and osteoporosis is also more common in individuals with NF1. So as far as less common complications, these malignant peripheral nerve tumours can occur, and as I said before, they tend to occur in adolescents and young adults. The bone abnormalities, usually congenital, and scoliosis tends to occur in adolescents. Neurofibromatosis, or NF1, is a progressive condition, so people tend to develop more complications as they get older, but it is incredibly variable. So individuals can be very mildly affected and may not even know they've got NF1, or they may not know about this diagnosis until their child is diagnosed. In this photo here, this man here has a plexiform neurofibroma, and this girl here at 17 doesn't have any obvious neurofibromas. But it's likely that as she gets older, she will develop some cutaneous neurofibromas. It's just that we're unable to predict, based on her genetic testing, how many neurofibromas she will develop. I'll just go over the diagnostic criteria before we specifically talk about the cutaneous neurofibromas. So a diagnosis of NF1 should be suspected in individuals who have any of the following features, and a diagnosis is confirmed when an individual has any two of these features. So the first one is 6 or more cafe-au-lait spots, the freckling in the axillary or inguinal region, 2 or more neurofibromas or 1 plexiform neurofibroma, an optic nerve pathway glioma, 2 or more leach nodules. So we often ask parents to have their eyes tested as part of the workup if the child's been diagnosed with NF1. If a child has a congenital bone abnormality, that's part of the diagnostic criteria. We should always think of NF1 if a parent has the diagnosis. And a positive test result is also one of the criteria. And so often we'll see children who might have a number of cafe-au-lait spots, but they don't have any of these features. And so because these features tend to come on over time. But if parents are concerned, we can offer a gene test to confirm that diagnosis. Although most people haven't had a genetic test because the diagnosis can be made clinically. Adults may wish to have a genetic test if they're planning children and want to consider options to prevent passing the gene change on. And if you're at that age and you want to talk to someone about that, I would suggest talking to a clinical geneticist about testing for that purpose if you wanted to. You don't need to do that. So these cutaneous neurofibromas, this is a man here who has a moderate number of neurofibromas on his back. These are soft, fleshy, benign, they're non-cancerous tumours or growths. They can appear during puberty, but not always, but they tend to appear in early or mid-adulthood. And they tend to increase in number with age. Close to 99% of adults who have NF1 will develop cutaneous neurofibromas. However, they may have less than 10, or they may have thousands. And at the moment, we can't predict what that trajectory looks like. They can vary in size from being sort of a few millimetres to being a few centimetres in size. This table just shows the number of neurofibromas increasing with age. So this was in 728 subjects. And if we have a look here at the cutaneous neurofibromas at greater than 100 in number, very unusual to have greater than 100 at a young age, but as you get older, the chance of having greater than 100 neurofibromas increases. And it's difficult to know exactly how many people have thousands, but certainly about 50% of adults with neurofibromas report that they have a significant number that they can see and that they're concerned about. For the vast majority of people, the result of their genetic test is unable to predict the numbers of neurofibromas they will develop. There are a few changes in the NF1 gene which can predict, but the vast majority, that would only be a couple of percent, the vast majority of individuals, once we give them their genetic test result, we're unable to say how severely affected they will be. We also know that even in families that carry the same genetic change, a mother might be mild, but their child might be more severely affected. So there's something else going on. It's not just the change in the NF1 gene that's affecting this. There seems to be other genetic factors coming into play that we don't understand. Health-related quality of life includes the impact of health, illness and treatment on physical, mental, emotional and social functioning and one's sense of well-being. We know from a number of research studies that adults can experience considerable anxiety and depression due to the presence of these cutaneous neurofibromas. And adults report that these cosmetic changes as their greatest burden of living with NF1. There are limited treatments, so it is possible to have some of the lesions removed by surgery or laser, but there's no pharmaceutical treatment or medicine that we can give people once they start developing these tumours to either slow the growth or to prevent the growth altogether. These two girls have been diagnosed with NF1, and the quality of life for children and families can be adversely affected as doctors are unable to predict the course of the condition over time. Children and their families can experience significant anxiety because of this varied symptom expression. So they might go to a camp or go to clinic and they see adults who are more severely affected, and they're worried about what's going to happen to them, which is really natural. And it's really difficult as doctors when we're unable to help them understand the course of their condition. Parents can feel out of control, and some parents live with fear and uncertainty about their child, really wondering how severely affected would their child be. And living with that uncertainty can be challenging for parents as well as the children themselves. So my daughter's now 23. When she was diagnosed, I experienced significant loneliness, a feeling of helplessness. I felt really frightened for her. I didn't know what complications she was going to develop or how severely affected she was going to be. I describe what I would call as a chronic grief. So it started early when she was young, but it never really went away. And she'd be horrified if she knew that I still feel this about her, and that I worry a lot about what the future holds for her. So the grief, I think, does incorporate into your lifetime and your life cycle, and you sort of get used to it a little bit, but it never really goes away. And it's the grief that most parents who have a child with either a medical condition or a disability feel. When she was diagnosed, I felt I was a bit close to home for me, and I felt like, look, I would leave this research to NF1 to someone else. There are lots of people doing research, and I felt like I wasn't in the right headspace to tackle that at the moment. But what I did do is I became, at that time, quite interested in rare diseases overall, because as a clinical geneticist, I see lots of patients, including patients with NF1 who have rare diseases. So what I know is that a rare disease, or I suppose NF1 is one of a number of rare diseases, and there are around 7,000 different rare diseases. And each of these conditions has a prevalence, so less than 1 in 2,000. So you need 2,000 people to have one person with a particular disease. However, even though they're individually rare, they are collectively common. And it's certainly not it's quite common to know someone who has a rare disease. And I remember we used to go on holidays as a group of families, and in our group of families there were 3 children who had rare diseases. People with rare diseases often have very complex needs and face unique challenges that aren't always easily met by the current health system. They are also referred to as orphan diseases because traditionally they were neglected by governments and funding bodies. What I noticed around this time, so this was around 2010, is that Australia was well behind other developed countries with respect to our national policies and plans for rare diseases. And we didn't have dedicated research for rare diseases, whereas countries like France and Germany and America and the UK did. So in those days, if you were applying for research, you were competing against, you really needed to fall into one of the priority areas at the time, which were cancer and diabetes and asthma and mental health. They're all really important, but it would be difficult to write a grant addressing a rare condition. This slide here shows a group of people in France, and all these people have different rare diseases, and they were marching at Parliament to lobby for their national rare disease plan. And what they did is they had to pick up someone else's rare disease, so they're not carrying their own rare disease, so that collectively they came together to try and tell people about the need for these conditions. So in 2012, I, along with 2 other mothers of children with rare diseases, so there was Leslie, who had a child with Duchenne muscular dystrophy, and Megan, who had a child with Fabry disease, we got together and we co-founded a non-for-profit organisation called Rare Voices Australia. That was quite challenging for me. I'd never set up a non-for-profit or written a constitution or done anything like that, but it felt right, and that's what we decided to do. We developed a logo. We called our organisation Rare Voices Australia. And one night I came up and I said to the girls, I had a vision during the night of a flock of birds, but different birds all flying together. And so this became our logo, which is different birds, The fingerprints, which you can't see very well, represent the fact that most or 80% of rare diseases are genetic and that we're all individual. So our goal was, we were dedicated to working with all the stakeholders to drive the best outcomes for Australians living with rare diseases. And we were really pushing for a national plan for rare diseases, similar to what was present in other countries. Early on, we were able to get some funding, just from small amounts of funding from different pharmaceutical companies, which was very helpful. So here we are. We did a number of events every year. We would lobby at Parliament House, and I was privileged to give a number of speeches at Parliament House. And this is Justice Kirby, who was our patron here as well. Our CEO, which is Nicole Millis here, she worked tirelessly in the development of a national rare disease framework. So our framework was covering these areas. So diagnosis, many rare diseases have a delayed diagnosis, on average 5 years delay. Access to treatment, many rare diseases don't have a treatment. And if they do, they're not under the PBS. It's very difficult for people to gain access to these treatments. Data collection was important because rare diseases were usually classified under our system in medicine as other. So we're unable to say, how many people in Australia have rare diseases without registries. And so it's difficult to work out what the burden was. Coordinated care and access to services, again, very challenging for people with rare diseases due to problems accessing services. They often need to see multiple doctors, and this is a particularly problem in rural areas. And the other problem was coordinated research. So in 2020, and you'll note this date is just before COVID, so we just got in time, Minister Hunt announced the implementation of a national rare disease plan for rare disease. This makes me a bit teary thinking about this because it was really such a lot of work. It was 8 years in the making, and it was a very special time. And here we've got Minister Hunt, and we've got Nicole, who was instrumental in our lobbying. She was our CEO. And the pillars of this strategic plan were around awareness and education, care and support, and research and data. The action plan included a boost in support of rare diseases and rare cancers, which is very exciting for the rare disease community and the rare cancers community. In 2020, I stepped down from being a co-director of Rare Voices, and I decided I would have another look at NF1. What I found was that there'd been lots of advances in the treatment of plexiform neurofibromas, which is good because these tumours often occur in children and they can be very disfiguring, they cause pain, and as they grow, they compress on other structures and cause lots of problems. And they also are at risk of malignant transformation. So it's great that a lot of people have been concentrating on plexiform neurofibromas. And there's a group of drugs called MEK inhibitors, which have had preclinical and some clinical trials and success for the treatment of these rarer complications, but important complications of NF1. However, there was still no pharmaceutical treatment to treat or prevent the cutaneous neurofibromas, which are actually cited as the greatest burden of living with this condition. Despite knowing that the NF1 syndrome and its manifestations are caused by a NF1 tumour suppressor gene, there was still little understanding of why these multiple manifestations of NF1 varied so much in different people. So that's something we still don't understand. So if we look at these cutaneous neurofibromas, a cutaneous neurofibroma is a histologically benign mixed tumour, so it doesn't turn into a cancer. It's, sorry, it's going to have a bit of water. It's combined of Schwann cells, fibroblasts, and immune cells, and they grow from these small nerve endings. They can be different types, so they can be flat, or they can be a little bit elevated, or they can be quite globular. And we don't really know whether these are different subtypes or whether these might be different developmental stages. The cutaneous and plexiform neurofibromas arise from the Schwann cells of the nerve cells. This is an example of a plexiform neurofibroma. So they're often diffuse. They can usually soft, but they can be harder. And this is a little boy here who's got a plexiform neurofibroma on his eye. But they are biologically, clinically, and pathologically different to the cutaneous neurofibromas, which is what we're working on. These plexiform neurofibromas are often congenital and progress predominantly during childhood and adolescence. So if you don't have one already, you're unlikely to develop one, but they do carry this risk of malignant transformation. They can be visible on the body, but sometimes they can be inside and only detected by body imaging. And as I said before, there has been advances on a preclinical and clinical as far as treatments for these plexiform neurofibromas, which is great because they can be very disfiguring and very challenging to treat. So this slide just shows a Schwann cell. So this is a nerve cell, which is called a neuron, and this is the body of the nerve, and this is the axon where the nerve's impulse goes through. And this is the Schwann cell. So what it does is the Schwann cell makes the material called the myelin sheath. It wraps around the Schwann cell. And this myelin sheath causes the nerve impulse to travel more quickly. So what we know is that there's something going on in these Schwann cells that causes the development of these cutaneous neurofibromas because they all arise from these Schwann cells. So breast cancer arises from breast cancer cells, but these cutaneous neurofibromas arise from these Schwann cells. So the NF1 gene encodes a protein called neurofibromin, and the next few slides are have a bit more science, but there's not too many of them, so stick with me. I will go slowly. So this is the gene, and it makes a protein called neurofibromin. This is what's called our karyotype or our chromosomes. And our chromosomes are present in every cell of our body, and we have 23 pairs. We actually inherit one copy of each of our chromosomes from our mother in the egg and the other from our father in the sperm. And so that's how our genetic material is passed on. And when we make our eggs and sperm, we halve our genetic material. So our eggs get one of each, and the sperm get one of each, and that's how the baby gets a chromosome 1 from mum, a chromosome 1 from dad, and a 2 from mum, and a 2 from dad, and so on, and that's how the genetic material is passed on. The NF1 gene is located on chromosome number 17. So we all have 2 copies of the NF1 gene, and it's making a protein called neurofibromin, and hopefully in most people that gene is working properly and it's making the normal amount of this protein which is functioning properly. This gene is really important in controlling normal cell growth. So people who have a change on this gene have got a change in their ability to control cell growth and specifically affecting these Schwann cells in the nervous system. So on this slide, what we're showing here is our chromosomes. And if we take a cell, so we have a copy of all of our chromosomes in every cell of our body. If we take a chromosome out and we unravel it, we get a long bit of DNA. And this DNA is made of a chemical code. So later on, when I'm talking about a spelling mistake in your gene, we're talking about a change in this chemical code. And just to give you an example, we've got 20,000 genes, and altogether there are 20 million codes, letters of DNA code. So there's lots of letters in our DNA. Now, if you break up the DNA into a section, one section is called a gene. So we're talking about the NF1 gene. So it's a section of DNA. It's on chromosome 17. Everyone's got 2 copies, one from mum, one from dad. And it has an important role, and it controls cell growth in the Schwann cell. So what does this DNA do? Well, this is another drawing of a gene, and here's our code. And there's lots and lots of chemical codes. The NF1 gene is very large, so there's lots of potential spelling mistakes that can go wrong in this gene. But when it's working properly, what it's doing is making a protein. If there's a problem in the recipe, then the protein doesn't work properly. And the analogy is a recipe making cookies. So if the recipe leaves out a cup of flour, then there's a problem in the cookie making. So what we're trying to do is that people who are carrying a change in their NF1 gene one copy of their NF1 gene isn't making this protein or the neurofibromin, and it's not doing its job properly. So cells are able to make a copy of themselves. So imagine we all start life as one cell after the egg and sperm have come together. And then that cell makes lots of daughter cells, and we're able to make a copy of it ourselves. Every time a cell makes a copy, it has to copy its DNA. And every time DNA is copied, there's a potential that a change occurs, a mistake, or can be called a mutation, I'll call it a change, can occur in that DNA cell. But the body has lots of mechanisms for noticing these changes and fixing them. And that's a whole topic called genomic stability. So our DNA is getting changed all the time, but our body is trying to fix it. And if cells have got changed DNA, the body also has mechanisms to try and to remove those cells. So all the time, as we're getting older, we are accumulating gene changes or mutations, which is why we age and why we're more likely, in the general population, people are more likely to develop cancers as they get older. So normal cell growth is very important to control, especially during fetal development and throughout life. So you can imagine a fetus is really very programmed cell growth going maximally, very, very fast. It knows exactly when to turn on, exactly when to turn off, and it's a miracle of how that happens. Some genes provide the recipes for making proteins that control growth. So we've got lots of proteins in our body. Some of them are in our hair, in our skin, in our bones, but there are specific proteins that are involved in turning genes, growth genes, that are involved in turning growth on and off. So if you cut your hand, your body knows to grow and heal, but then it knows when to stop growing. So it's very complex, this whole mechanism of controlling cell growth. Genes that turn on cell growth are called proto-oncogenes. So these are normal genes we all have that turn on growth. And genes that turn off growth are called tumour suppressor genes. Again, these are normal genes. We've all got them, and they turn off cell growth. But we know that there's problems with these types of genes, that it can cause cancer or tumours, which are benign or cancerous. So the NF1 gene is a tumour suppressor gene because it turns down cell growth. So it's normally there, it's involved in just keeping the dampener on cell growth. This is a complex pathway, and I don't expect you to know this, but I want you to see this. This is the NF1 protein, and what it does, it turns this pathway on. And, well, actually, it turns it off. So when this protein's not working, this pathway is turned on more, and we're going down to cell proliferation or cell growth. So its role normally is to keep this, sort of dampen down this pathway and to keep it under control. So you can see if somebody's NF1 gene is not working properly, there is this change where we're heading, where the body is causing cells to make copies of themselves and grow. Now, that's really what happens in most cancers, is that there is this uncontrolled growth or proliferation of cells that cause a cancer. Even though most of the cutaneous neurofibromas are non-cancerous, it's a similar mechanism. So again, the next couple of slides, we'll just go through for people who are interested in tumour suppressor genes. But most people have heard of a breast cancer gene called BRCA1, and when women have that change, it causes them to have an increased risk of breast cancer. So that's unrelated to NF1, it's just an example. So the breast cancer 1 gene is another tumour suppressor gene. Most people, the women who have breast cancer have the breast cancer 1 gene, inherit a copy in the first in their breast cancer 1 gene, either from their parents, and they've got a copy on one copy in every breast cell. And then over time, a breast cell might develop a second copy, and we call this a second mutation or a second hit. And now this cell, that gene's not working properly, and they get cell growth, which can lead to breast cancer. So it's similar with NF1. So people with NF1 have inherited a change in every cell of their body, including the Schwann cell. Schwann cells are okay. Once they, as you get older and things are changing, this Schwann cell can get a second change, and then you get the development of cutaneous neurofibroma. This shows that again, this is somebody who has two normal copies of the NF1 gene. If they get one change just over their life, the cells are okay, but you need two changes for the Schwann cell to grow and a neurofibroma to develop. So the NF1 gene is just one of a number of different tumour suppressor cells, and there are many genes that are important in most cancers. But people with NF1 are sort of one up step of cell growth because they've got this change they've inherited or have had in every cell of their body. So the first cell that starts a new cutaneous neurofibroma has a change on both copies of the NF1 gene here. And in each cutaneous neurofibroma, a second change is present. So when scientists have gone and looked at the cells of cutaneous neurofibromas and looked at the DNA, they've noticed that all the cutaneous neurofibromas, when they look at the DNA, have got two changes in the NF1 gene, where other cells in the person's body have just got one. So we definitely know that the cutaneous neurofibromas are because this genetic change is happening. What is very important is that this second change is different in every cutaneous neurofibroma. So the spelling mistake on all different neurofibromas, if you took someone's neurofibromas and looked at them all, the second spelling mistake or change in the gene is different. So something's happening and the second change is happening, but we don't know exactly why or what's happening. So the Holy Grail, one of the big questions in medicine, and it's not just relevant for NF1, but it's relevant for all cancers, because most cancers, regardless of whether they're inherited, are often related to a second hit or the second change in a tumour suppressor gene. So what we don't know is what protects an individual from getting this second change in a tumour suppressor gene. Why do some people get cancer and other people don't? Or why do some people with NF1 get lots of new cutaneous neurofibromas and other people don't? So the hypothesis is that there are other genes in our genetic background, one of those other 20,000 genes, or maybe a group of them, that influence our NF1 gene and can influence the number of cutaneous neurofibromas an individual will develop. And there are lots of genes, hundreds of genes, or probably thousands of genes that also are involved in cell growth that might either protect an individual or increase their risk of developing large numbers of neurofibromas. These genes are what we call modifier genes. So there's been lots of other conditions where people have found modifier genes that affect how that disease manifests, but there hasn't been this for NF1 and cutaneous neurofibromas. And as I said before, there's many different genes that are important in cell growth and repair of our DNA. And this is just, we don't need to go through this, but this is an example. So there are genes involved in how our DNA, sort of the maintenance of it, so repair of it. There are genes that might cause more DNA damage. There are genes that are involved in removing cells where there's damage. So there's lots of different mechanisms or genetic background that could influence a person with NF1 and why they've got a more severe disease than someone else. So early last year, I had been thinking about doing a particular research project, and I woke up one morning and checked my email, and I just could not believe my eyes to find that the MRFF had actually advertised a funding opportunity specifically for neurofibromatosis. And I suppose that really shocked me because for me, 10 years ago, you would never have seen a round just for a rare condition like NF1. And I'm very thankful to the Children's Tumour Foundation, who lobbied Minister Hunt for this research opportunity, and I understand they spent a lot of time and there were a lot of patients involved in that lobby. So we saw this grant opportunity, and so I'd already been thinking about this idea with Professor Murray Kane and John Attier and Rodney Scott. And so at that stage, we quickly got together a large national and international team to work on this research proposal. And we were able to submit that proposal, and we were one of the successful candidates. So there were a number of projects put forward, and I think there were 4 successful projects. So we were awarded $1.6 million to look at or to develop a cohort, so a group of adults with NF1, so that we could study their genetics background to try and understand the differences in their cutaneous neurofibroma numbers. This is our website, which has been established, and this is Janu, who's the ambassador for the Children's Tumour Foundation. She's kindly agreed for us to use her image on this site. So our research aims are to partner with adults. We can't do this without the NF1 community, to try and improve our understanding of how our genetics affects the number of skin neurofibromas a person with NF1 can develop. And then how, hopefully, by understanding the pathways involved in these tumours, that it might lead to a treatment in the future. And there's actually lots of medications out there now that can be used. So we may not necessarily need to develop new treatments, but by understanding the pathway, you can repurpose current drugs to try to see whether we can come up with a treatment that might influence this condition. So how can adults with NF1 contribute? So all adults, regardless of whether you have a clinical or a genetic diagnosis, as long as you're over 18, we would love you to participate in this project. We're happy to have adults who are severely affected, mildly affected, moderately affected, or don't even have any cutaneous neurofibromas, because by looking at that group of people, it will give us an idea about what genes might affect it. So sometimes an 18-year-old might have lots of neurofibromas, but another 18-year-old may not have any, but that's still important for us to have both those individuals in the project. The first thing you need to do is go to our website and register. And we're asking a fair bit of you, but we're asking you to provide photographs of the skin on your abdomen, neck, and arms. We'll be asking for medical information and consent to supply a saliva sample. When you go to the site, there'll be a consent form that you can read. And because some people have phonetic dyslexia, we've recorded all the websites, so you can click here and listen to it rather if you're feeling tired and don't want to read all the information. And you can consent to enrol in the project, but you can also consent to be contacted about other projects, for us to hold on to your DNA for other projects, or to give consent consent to be involved in other projects. So if you don't consent for us to keep your de-identified DNA, then that will be disposed of at the end of the project. So what will we do with your photos? These photos are securely stored at the University of Newcastle server. The photos are given a code, and so they're not stored with your name. So they're kept very securely. The photos are really important because they're going to help us understand. We need to look at the number of cutaneous neurofibromas an individual has to be able to compare them with the person's background genetic information to help us understand what genes are important. So the photos are a really important part of the project. There's a questionnaire, and this is only a bit of it. It should take probably about 15 minutes. It might take a little bit longer, but it really just gives us a background about what other features you have, what your diagnostic features are, whether you've had any removal of your cutaneous neurofibromas, whether you've had any treatment of your cutaneous neurofibromas, and what other complications you've had. And then once that's finished, you'll be asked whether or not you're happy to have it says here a blood collection, but we've decided to send out saliva kits because we think that will be easier for people to collect. So that will change soon on our site. What do we do with your saliva? We're going to extract your DNA in the lab. We give the DNA a code, so again, it's separate from your name. And we'll be doing something called a genome-wide association studies. So we're looking at all those 20,000 genes, plus we're looking at the rest of your genome because the genes only account for 1% of your genome. And we're trying to understand how changes in your genes influences the number of cutaneous neurofibromas that you will develop. How do we keep it safe? Your information is stored away from the public site, so no one else can access your images on the public site. Again, we give everything a secure code. And I'm the only person that can link your code with your name. And again, your photographs and name will not be used in any talks or publications. When you're in clinic, you may get a copy of this brochure, or the Children's Tumour Foundation may send you a copy. But if you go to this QR code here, that will take you to the site. If you are wanting to Google the site, you need to put in NF1 project all as one word. So it doesn't seem to come up if you put NF1 gap project, but if you put NF1 project as one word, the project site will come up on a Google search. So, but if you have any problems, then you can either contact someone from the Children's Tumour Foundation, or you can, there's a information email here. So that's info@nf1project.com. I'm hoping that we can make progress together. Obviously, this is a personal endeavour for me, but also I look after lots of patients with NF1, and I feel incredibly humbled and grateful to have an opportunity to make a difference in the lives of people with NF1. And I hope that this project is a stepping stone to us one day understanding and developing a treatment for this condition, as for this particular part of the condition, which is the cutaneous neurofibromas. I have a really large team that we're working with. So Professor Murray Keynes is doing all our genetic work. John Attier is the Professor of Medicine here at University of Newcastle and has expertise in study design. Gareth Evans is one of the experts in NF1 who works in the UK. So we will be recruiting people in the UK and internationally into this project. And these are all the other people who are on the grant. You may end up talking to Elizabeth Rowe, who's our project officer. So when you register, if you don't complete or you've got any problems, Elizabeth will talk to you. But I'd really like to thank not only the NF1 community, but the Children's Tumour Foundation and the Medical Research Futures Fund for allowing us the opportunity to explore this problem and to do this research. So thank you. Thanks for listening today.